Good afternoon and welcome to today's virtual satellite symposium, Exercise and Cancer, Best Practices from Around the World, presented by Technogym. A few notes to our attendees. Today's symposium is totally web-based. If you experience audio difficulties or if the video begins to buffer, it's likely caused by the strength of your internet signal. If you are having issues, try logging off and logging back on. If you have a question during the webinar, please type it into the question area within the GoToWebinar navigation, and our presenters will cover as many as they can at the end of the presentation. We also encourage you to join the conversation about today's symposium on Twitter by using the hashtags ACSM Webinar and Technogym. Today's symposium is presented by Technogym. Since 2010, Technogym and ACSM have partnered on exercises medicine to encourage primary care physicians and other healthcare providers to include exercise when designing treatment plans for patients. EIM and Technogym are both committed to the belief that exercise and physical activity are integral to the prevention and treatment of chronic diseases. As a result of this ongoing partnership, Technogym has helped EIM expand to more than 40 countries, making it a true global multi-dimensional initiative. I'd now like to introduce today's speakers. Dr. Catherine Schmitz is a past ACSM president, a distinguished professor in the Department of Public Health Sciences, and the director of the Oncology Nutrition and Exercise Group at the Penn State Cancer Institute. Dr. Schmitz's research focuses on people living with and beyond cancer and investigates the role of exercise in improving physiologic and psychosocial outcomes. She is also the founder of the Moving Through Cancer initiative within ACSM's Exercise is Medicine program. Dr. Quinn Pauly is the Chief Medical Officer at Switch, a technology infrastructure ecosystem corporation whose core business is the design, construction, and operation of the most advanced data centers. He is also the head of Switch's Life Muse department, Switch's Health and Wellness division. Dr. Pauly's mission is to help improve the health and well-being of all Switch team members and his patients. Dr. Pauly is the president of the Nevada Physician Wellness Coalition and immediate past treasurer of the American College of Lifestyle Medicine. And Dr. Silvano Zanuso is the scientific director at Technogym and visiting professor at the University of Coventry in the UK. Dr. Zanuso's primary scientific and research interest is on the effects of physical activity and exercise in those with metabolic disorders, and he publishes regularly on this and other topics in recognized scientific and clinical journals. He has been a consultant for health promotion for different governments and public institutions, and he has held conferences and educational programs in more than 20 countries. Today's first session is presented by Dr. Catherine Schmitz.
Hello, my name is Dr. Catherine Schmitz. I am a professor at the Penn State Cancer Institute and author of a forthcoming book called Moving Through Cancer from Chronicle Books, available for pre-sale now. You see my social media hashtags on this front slide as well, because I believe we are at a tipping point in the field of exercise oncology, and that getting the word out is going to be a good portion of what is important. As I begin my talk, what I want to point out is that in the field of exercise oncology, we have had an exponential growth in the number of randomized controlled trials since in the period of time between the first ACSM Roundtable, which occurred in 2009, and the second ACSM Roundtable, which occurred in 2018. And so as a result of that exponential growth in the science in the field, ACSM felt it was time to have a second international multidisciplinary roundtable. I was very proud to co-chair this with my colleague, Chuck Matthews from the National Cancer Institute. We were very purposive in making sure that we had all of the different types of physicians and professionals, healthcare professionals in the room who touch the cancer patient and survivor. So we had medical oncologists, we had epidemiologists, we had surgeons, we had family medicine docs, and oncology nurses, and physical therapists, and rehabilitation doctors, et cetera, et cetera. We also had a substantive international presence at the meeting. The result of the roundtable was 3 different publications, which were released in October of 2019 and form the basis of much of the rest of my talk. The first of those 3 papers was quite ably led by Dr. Alba Patel, a senior epidemiologist at the American Cancer Society. And what Dr. Patel focused on in her paper was cancer as an outcome, incidence and mortality. So does exercise prevent cancer to begin with and prevent recurrence or mortality? And so what we are able to conclude on the basis of a high-level review of reviews for this paper was that there are 7 common cancers for which there is substantive evidence that being more physically active will prevent that cancer, including breast, endometrial, kidney, bladder, esophageal, stomach, and colon cancers. And in the fine print at the bottom in pink, what you might also find is that there is substantive evidence of a reduction of the risk of recurrence and mortality from breast, colon, and prostate cancers after a diagnosis of cancer. Being more physically active is protective. There was more that we were interested in, though, beyond cancer as an outcome. We were interested in other cancer health-related outcomes, such as symptoms, treatment tolerance, and adverse effects of treatment. And so there was a second paper that was quite ably co-led by Kristen Campbell and Carrie Winter-Stone that focused on this issue. And what we were really interested in this particular paper was what we call the fit prescription. And so I'll draw an analogy that we don't prescribe to the patient to go get some chemotherapy. We give them a particular frequency of chemotherapy, intensity of chemotherapy. We give it in certain cycles and a distance of time in between each of the cycles. And we give particular types of drugs for particular types of cancer. So in order for us to move exercise from a nice to have to a must have during oncology, we wanted to know if we could prescribe exercise like a medicine with this fit prescription. But to do so, we needed to have some kind of rubric to decide whether the science was sufficient for us to draw that fit prescription or not. We borrowed from the Dutch National Physical Activity Guidelines for this purpose. And if you note on the left side of this slide, you'll see we started with review of nothing but randomized controlled trials. We had 16 cancer health-related outcomes we were interested in, and we looked to see if there were randomized controlled trials on each of those topics. If there were fewer than 5, we decided there was insufficient evidence. If there were at least 5, the effect was not close to 0, and there was some either consistency in evidence and strong level of evidence or an emerging evidence of potential benefit, then we drew either a strong or a moderate level fit prescription. And of the 16 cancer health-related outcomes that we were interested in, we drew the following conclusions. There was strong evidence for a fit prescription for anxiety, depressive symptoms, fatigue, health-related quality of life, breast cancer-related lymphedema, and physical function. We showed moderate level of evidence for a fit prescription for bone health and sleep, and all of the 8 outcomes that are listed under the red insufficient label were noted as having insufficient information in the literature for us to draw a fit prescription. So we have been very interested at ACSM and in the Moving Through Cancer initiative in the concept of translating this evidence base into format that is really usable by the cancer clinician, by the cancer patient, and by the cancer caregiver. And so this is the 10th version of an infographic that has been developed to try to put together all of the information and all of the evidence that I have just shared with you. The top half in various shades of blue communicates the public health guidelines for physical activity. They're agreed upon by the US Department of Health and Human Services, but also by the World Cancer Research Fund, the WHO. Around the world, we are all in agreement that everyone should be moving more, sitting less, and getting 150 to 300 minutes a week of aerobic activity and twice weekly strength training. Second half, the lower half of the infographic shows you icons for the 8 health-related outcomes that we think are actually positively altered as a result of being more physically active during and close after cancer treatment. The green icon is intended to denote cancer-related fatigue. And if you look at the bottom of the page, you'll see green dots, and that shows that aerobic exercise, resistance exercise, and the combination of the two will be helpful for cancer-related fatigue. By contrast, if you look at the pink bone health icon, and you look at the bottom of the page, you'll see that it is only resistance exercise that is helpful for bone health, according to what is published in the literature. So moving further into the direction of trying to translate this evidence base into clinical practice, I led the third paper coming out of the Roundtable, which was called Exercise as Medicine in Oncology. And our goal here was to lay out the current state and to set the stage for the changes that might be necessary in oncology in order for us to make exercise standard of care during and after cancer treatment. So the current state is that less than 25% of cancer patients are adequately physically active. There are a multitude of reasons for this, but we felt that it was time for the American College of Sports Medicine to step forward and to answer this issue. And so the first disease-specific initiative has been born under the umbrella of Exercise as Medicine, and that initiative is called Moving Through Cancer. The Moving Through Cancer Task Force, which are the leaders of this initiative, came together for a retreat in May of 2019 in order to set the agenda for this bold initiative. And we included an oncology nurse, medical oncologist, a policy expert, a practitioner, a rehabilitation doc, a physical therapist, and of course a postdoc. And our goal for our retreat was to state upfront that if the goal is for exercise to be standard of care in the setting of oncology by 2029, answer this question: what needs to happen for that to be achieved? We have published our agenda setting paper in the journal Cancer, and I commend that to you. And we found that we had 5 agenda areas that were particularly important, and I'm going to go through each of these with you today. So in the area of workforce enhancement and program development, what we were particularly interested in is preparing exercise professionals to work in oncology. And the first thing we're doing in that area is a Delphi process to define what is good, what needs to happen for an exercise professional to be ready to work in the setting of oncology. We are also working to make the CAN rehab program that was so brilliantly developed by Anna Campbell one of the ACSM available programs as well. We are interested in elevating awareness of exercise in oncology healthcare professionals, and we are very interested in program development. We have developed a registry that I'll show you in just a moment. We're approaching 1,800 programs in that registry from around the world. We are in the process of IDing programming in the US in particular, and then we will expand beyond the US. And we're working to find 2 national brand fitness organizations who are willing to train their staff nationally so that those can be the gyms that cancer patients know this is a place I can go to work with well-trained professionals. So the the registry for Moving Through Cancer is shown here. If you were on this page, you could click on the green bar that says Exercise Programs Registry, and it would give you the option of choosing country and then type of program: online program, virtual program, one-on-one, rehabilitation focused, hospital-based, community-based. So there's 1,700 plus programs in that registry right now, and that's expanding over time. We're also in the process, as I said, of trying to expand the knowledge of where the programs are across the United States. And so this is as of last fall. We haven't done an update in a couple of months, but you can note that the darkest 2 states on this map are New Jersey and Texas. And that's not actually that surprising if you know about the Live Strong at the YMCA program, which is a very strong, ubiquitous program across the United States. And they have particularly focused in New Jersey and Texas as places where they have disseminated that program. We're also really interested in research and evaluation, and I do mean those as 2 separate issues. research and evaluation. So certainly we need to do continued research on efficacy of exercise interventions, particularly for treatment-related outcomes. But there are many, many, many exercise oncology programs already in existence around the world. We need to do a better job of evaluating those programs. We need to evaluate the cost and cost effectiveness of those programs. And we need to develop a service costing template so that programs around the world can tell their funders how much it costs per person to deliver the program to a patient. And we need to understand better by doing those kinds of evaluations what the secret sauce is for successful programs. We're also interested in stakeholder awareness. We're interested in nothing less than ensuring that everyone living with cancer is aware of exercise benefits. When you talk to the average person anywhere in the world about the idea of, hey, would you ask a person going through cancer treatment to exercise? They might look at you a little funny because they think that cancer means you rest, take it easy, and don't push yourself. So we need to change that. We need to change that culture of cancer so that people understand that moving through their cancer treatment is actually the right idea. We did this with cardiovascular disease before. We've done it before with back pain. We can do it with cancer as well. So the things that are happening through the Moving Through Cancer initiative in this regard include the development of a brochure and a prescription pad that I'll show you in just a moment. We are also members of the National Accreditation Program for Breast Centers and Standards and Education Committee to raise awareness for breast cancer in particular. I've mentioned the registry before, and we have a number of goals in the area of stakeholder awareness, empowerment, and engagement. We seek funding for all of these activities, obviously. So our Moving Through Cancer prescription pad should look quite familiar to anyone who is familiar with the Exercise is Medicine prescription pad, which is also available online. But this one, if you look carefully, actually has a different dose of exercise because it reflects the current evidence for the amount of exercise and the fit prescription that should be given for the vast majority of the 8 cancer health-related outcomes for which we have documented that there is a substantive benefit during and after cancer treatment. So we've developed this infographic that I've shown before, but in addition, we did some testing with patients and found that they thought that it was a little thick, that it was too much information on one page. So we've developed a 4-page brochure that goes with this infographic, and we have changed the language on it so that it is really friendly to cancer patients and at an 8th grade reading level. And we seek funding to be able to disseminate this across all of those 1,700 programs across the United States and beyond. We are certainly interested in policy funding and sustainability in the Moving Through Cancer initiative. We advocate for policies that support exercise oncology programming. Our current activities are that we are doing a substantive amount of research to understand the policies that underlie the development of sister types of programs, such as cancer rehabilitation, such as cardiac rehabilitation, such as the DPP. There are a number of other programs that could be looked at and evaluated to see how did they come into being, how did those programs succeed or not succeed, and what can we learn. We're interested in meeting with decision makers and understand better the ability of patients to pay for exercise oncology programming. Our goal is to have an action plan based on all of those statements that I just made by 2023. When I put all of this together, what I can say to you is that I am exceedingly grateful for the great collaborators that we have had in the Moving Through Cancer initiative. And I am delighted to have been able to have a few minutes to speak with you about those. And for reasons I don't know, my last slide isn't showing, but it shows all of the people that came to the Exercise Roundtable in 2018. And if you have any questions for me, if there's not a time during this webinar for you to ask those questions, I invite you to seek me out online or through social media. And I hope that this has been helpful to you and will be helpful for your practice. Thank you.
I am Quinn Pauly, Dr. Pauly. I'm a primary care physician here in the state of Nevada, and I've graduated from medical school back in 1990, so I've been doing this for quite some time and have some experience under my belt. And I'm here today to talk about exercise and cancer from the viewpoint of the primary care clinician, doctors, nurse practitioners, physicians assistants, and that kind of unique relationship that you have with the patient, and obviously in these the difficult time of making that diagnosis. So, we as primary care providers pride ourselves on, having the expertise to treat, 80-90% of the patients we see on a daily basis without the need to refer them further to a specialist. And, in the instance of cancer, however, that's the exception. We want to get the oncology team, the oncologists, the surgeons, the radiation oncologists, we want them involved as soon as possible, and as does the patient. But oftentimes the initial discussion with the patient to say, hey, this result came back and says definitively that you have cancer, or that it's highly likely, everything's pointing in that direction, but now we need to go prove it with a biopsy or some other test. That responsibility often falls on the primary care doc, and we're happy to do it, or not happy, but we realize that's our responsibility, but it doesn't make it any easier. It's a very difficult thing that none of us look forward to that, and it's just it's a life-altering event for the patient and the family, and for us too. And but we take that responsibility strongly, and so and it's all over the place in terms of what can happen that day. There are often a lot of questions and tears and sadness. So, it's very difficult. And so, despite us referring to the specialists, we want to stay involved. You want to be able to see the patient frequently and understand what they're hearing, understand how they're dealing with the treatment, and also we want to be able to recommend adjuncts to the Western medicine treatment that they're receiving on a daily, weekly basis that can help them as well. And that's really what we're going to talk about today. And again, it's a unique position for us to be in. We know the patient on a first name basis. Hopefully, they've been our patient for a while, and the patients really want us to co-manage them. And often I'll go visit the patient in the hospital, even though I'm not treating them there. Just to kind of let them know that I'm still on the team. And then they also we want to be able to give them the most evidence-based treatment recommendations that we can. And I'm convinced and confident that exercise, if I had to pick one thing amongst all the pillars of a healthy lifestyle, I think exercise is the thing that has at least as much evidence as the other pillars, and is often what I recommend they do first. So we're going to talk about that. So as Dr. Schmitz talked about, the benefits of treating the individual patient battling cancer of a healthy lifestyle is definitely exists. And that 2018 American College of Sports Medicine report that came out, that kind of validated what primary care providers had been doing and hoping for decades, was that exercise is generally safe for cancer survivors, and that every survivor should engage in some level of physical activity. So what we see on a day-to-day basis, when you're actually interacting with that individual patient, here are the things that I really see. So they come to us, we refer them on, they come back, and the frequent kind of scenario is they feel like they're not in control. They're like, I'm doing what they're telling me to. I'm taking the chemo. I'm doing the radiation. I've had the surgery, but I'm just kind of, an innocent bystander in all this, and not really in control. And so when you recommend exercise and give them something that they can actually do themselves, it really instills a lot of hope in them, and I've seen that time and time again. And again, we feel great because, hey, this is the best thing they can possibly do. So that really, sparking that hope in themselves and in their families, I think is super important. And then the other thing is that they're not a bystander. They are in control. They know, and explain to them that this is the most important adjunct that you can do to the rest of your care. So that in and of itself, I think, is worthwhile of making these recommendations, and then also improving their tolerance of the treatment. Going through chemo and cancer treatment in general, it's not fun. It's lousy, and patients feel lousy. And being fitter, having that, doing that regular exercise definitely improves their ability to tolerate the treatment. I'm convinced that the best treatment for cancer treatment-induced fatigue is exercise, better than anything else. And the fitter they are before, during, and after the treatment, the better they're gonna tolerate that. We've talked about just the increased survival of cancer, of patients that are exercised during cancer, certainly for breast, colon, prostate cancer. But I certainly haven't read anything that says exercise makes any cancer worse. So just that survivor talk to have with the patient, I think, is important. And the other thing isn't talked about quite as much is, the treatment is very toxic. We have no choice, to offer the best Western treatment, but the treatment itself can increase your likelihood of suffering and dying from lung disease, and affects your immune system and the cardiovascular system. I've got quite a bit of experience with setting up an intensive cardiac rehab program here in Reno, and that's the one chronic disease for some reason that Medicare decided to approve a very regimented treatment for, which is great. But we'll talk future states, but I'd love to see that same model reproduced for other chronic diseases as well, like cancer. So knowing that their increased risk of a cardiovascular event, that in and of itself is another good reason to recommend the getting started with a exercise regimen as well. And then just overall mental health, overall quality of life. I think all those things come into play. And but you do also have to be very individualized. A lot of our patients, myself included, could be doing a better job leading the healthiest lifestyle. And so for the recently diagnosed cancer patient who isn't exercising at all, if you just came out the gate and said I want you to start exercising 150 minutes a week and switch to a whole food plant-based diet, and eliminate all the toxins from your life, get better sleep, it's going to be overwhelming, and I think they're more likely not to do any of them. So you kind of have to pick and choose, and if they're not exercising at all, my first recommendation is always, hey, let's start walking. I recommend that we start there, and kind of bridging that chasm between what the science says and positively affecting a patient's behavior is really the crux of the matter. And as much as I'd love to say, hey, if I just tell a patient to do it, they do it, the science wouldn't back that up, and nor would my anecdotal experience. So kind of finding out where they're at and starting with what's most likely going to work. So, you know, when I was asked to contribute to this webinar today, my brain just immediately, and I haven't been able to stop thinking about a particular patient of mine who he was a male, late 50s. He'd been my patient for several years, and you know, try as I might, I couldn't get him to agree to do any colon cancer screening. And you know, I tried. I went back in my notes and I had documented it on multiple occasions. And you know, I don't know if it was a mental block on his part or whatever, but unfortunately, in his late 50s, he became symptomatic and then came back to see me, and we did a workup. And unfortunately, his colon cancer was fairly advanced when the definitive diagnosis was made. And you know, we talked and had you know, the heart-to-heart, if you will. And you know, the one thing that he really latched on to was he was going to exercise. You know, he was going to be in control at this point, and he did. You know, he really, you know, ramped that up and made it a daily thing. And you know, everything that I mentioned, the hope, the tolerance of the treatment, the you know, just his overall quality of life, you know, was definitely improved when he began that treatment. And you know, unfortunately, he died. You know, he died, you know, within, you know, a couple of years of when the diagnosis was made. And but till he couldn't do it anymore, he exercised. And you know, there's no way for me to know if you know, he would have lived less long had he not exercised. That's really not the point I'm trying to make. It was that you know, he was in control, and he definitely perceived his quality of life to improve. So so unfortunately, cancer is often a fatal diagnosis, and even if that happens, giving them some control, or having the patients be in control and knowing that they're responsible for their care, I think is super important. So having said all that, you know, I mentioned that, you know, the future state of hopefully having a more specific you know, place where primary care providers could refer patients who have that cancer diagnosis, and have a team, you know, help them work on all the pillars of the healthy lifestyle, I think would be ideal. And interestingly, when we were setting up our intensive cardiac rehab program, you know, you have to choose what gym equipment to populate your clinic with, and we, you know, this is 6 or 7 years ago now, that we just happened to choose Technogym as the gym, the equipment that we use, and we were very happy with it. And this was long before I engaged with Dr. Silvano Zanuso, who's going to talk now. And it's just funny how things kind of come full circle there. But so Dr. Zanuso is the director of Technogym's medical and scientific department. And without further delay, I will hand it over to him. So thank you for listening.
Good morning to all of you, or good afternoon, or good evening, it depends on where you are. My name is Silvano Zanuso, and I'm the scientific director at Technogym. Welcome to all of you on behalf of Technogym that I represent today. We have seen just now from Dr. Schmitz how effective exercise can be in the prevention and treatment of different types of cancers. And with Dr. Quinn, how a doctor, even a GP, can deal with his patients, suggesting correct lifestyle behaviors. And exercise is a major component of a correct lifestyle. Exercise therapy, we can say that is becoming a reality all over the world. And today I will present to you some best practices, each one with distinctive features, just to have some inspiration from something that really works. But just let me do a brief analysis on what have happened throughout the years when talking about exercise therapy. We can identify 3 different phases, as you see here in the slide. Phase 1, when exercise was considered dangerous. It was said that it can spread metastasis, or another typical saying was, patients are too tired after chemotherapy, let them rest. Then we moved to phase 2, where typically it was said to patients, just do some moderate intensity physical activity, no matter the type of cancer, the phase, etc. Just do some moderate intensity physical activity and you will get some additional benefits, not related to the tumor itself, but to fight extreme fatigue sensations, to improve your mood, etc. But now we are in phase 3, where not all around the world, but in the most advanced places, we know that exercise can have specific and direct effects on the tumor itself, on its proliferation, for example, and a lot of other positive side effects. We have now specific guidelines. We have specific guidelines, and I suggest you to consider those proposed by the Exercise and Sport Science Australia, the guidelines supervised by Professor Robert Newton. But now let's start with our best practices. And number 1 is that of Professor Robert Newton at Edith Cowan University in Perth, Australia. It is a scientific project on exercise therapy, and the name of the project is Accentuated and Eccentric Only Resistance Training. Let's talk a little bit about resistance training, and specifically about eccentric exercise. We know that eccentric exercise has multiple benefits, or I would have to say overloaded eccentric exercise has multiple benefits. Overloaded eccentric means a load that is higher in eccentric than in concentric. Here you can see the standard force velocity curve. And imagine that we are here lifting a load of 100 pounds at a certain velocity, concentrically, and we are here in this force velocity curve. Then, if we want to lower that load, we need to decrease the force of 100 pounds that we're applying. So if we decrease the force, we move from this first velocity to another first velocity curve, which is at a lower level of neural activation. If instead we were to use the same force velocity curve, we would have to increase the load in order to move along the same level of neural drive. And this is actually the main disadvantage of traditional strength training machines, that in order to lower the weight, to do the eccentric phase, the return phase, we have to de-recruit motor units, because the load is the same between the 2 phases. When we have a standard machine, the load is the same in concentric and in eccentric phase. And that's why Professor Newton is using this technology, or those Technogym robotic machines that allow in a very easy way to perform an overload eccentric contraction. The biocircuit, you see here some of those machines, is a series of machines that have electromechanical actuator. They do not have a weight stack. They have a motor generating tension that provide different resistances: isokinetic, isotonic, isoinertial, elastic. But on that study, they were particularly interested in the accentuated eccentric mode. Why? Because they are looking at that because sarcopenia, or low muscle mass, and cachexia, which is a low overall body mass, are major problems for people with cancer. And depending on the cancer type, it is around 2/3 of cancer patients that will suffer from sarcopenia or cachexia. So why eccentric exercise? Eccentric overloaded eccentric because it requires less energy than the concentric contraction, but it drives equivalent muscle size and strength, in particular in men with prostate cancer that receive androgen deprivation therapy. And this means that they do not have testosterone, and testosterone is a very important anabolic pathway. But interestingly, eccentric exercise uses different anabolic pathway, and it is independent to testosterone. That's why they want to test this specific contraction provided by those machines. But now let's move to another case study. Let's go to Italy. Here there is another project based in Urbino. It is called MOVIS, the MOVIS project. It is on women with breast cancer. And in this case, the form of a training is aerobic exercise. Again, it is a scientific project, a randomized controlled trial with its timeline. And the final goal of involving and testing in 3 years 172 women, 172 patients with breast cancer. Which are the particularities of this program? It is an exercise and nutrition program, and it is aimed also to stimulate the patients to train at home independently. As you can see here, 2 days a week training on site, 1 day a week training with remote supervision, and there is also a weekly healthy lifestyle reminder. So this is another interesting approach, having a clinical exercise center as a reference center where people can come, stay for a given period, learn how to exercise, and then they should be able to do exercise and physical activity at home. There are already the preliminary results of the trial that will be published soon, but in a nutshell, all the results, all the measured variables improve. Those related to exercise, look at the VO2 max, for example. Those related to physical activity, which is an independent dimension of movement, different from exercise. So they improve both the exercise capacity and the volume of physical activity they accumulate on a daily basis. And also the parameters related to nutrition improve. In this case, the adherence to the Mediterranean diet. So very, very interesting project with a peculiarity of having in mind the goal of improving exercise and nutrition, and that of teaching to patients how to exercise in a clinical setting in order to make them available to exercise independently at home. Now let's move to another project. It is called the OTT. It is a very well structured initiative in Germany. It originated from the Quinn University, but it has centers in various cities in the country. And the main idea behind the project is that to offer a training that is specifically tailored to the individual patient and to his or her physical and psychological conditions. The training protocols are the same across the facilities because they are based on scientific evidences. And we could say that overall it is a very comprehensive exercise program because the OTT offers a solution to different types of cancers. No matter the cancer, there is the scientific-based exercise protocol for any type of cancer. It offers a solution at different stages of the disease, from the early stages to the very advanced and critical stages. It offers a solution at different treatment phase, before treatment, during the treatment, after the treatment, and even as palliative interventions. And also very interesting, they do both in this project, standard training to patient, and they conduct research project, scientific research project. The technology they used is based on a system that allows to prescribe the correct exercise protocol to each patient in a precise and controlled modality, storing the results and being sure that the dose the patient is taking is correct. The circuit of machine they are using is called biocircuit. It is constituted by a combination of aerobic and resistance machines. Let's now move to the States, to another project, the last project that I'm going to present today in this brief presentation. It is the DigitX study, which stands for digitally enabled clinical trials of exercise therapy. It is conducted at the Memorial Sloan Kettering Cancer Center. Here you see two pictures, one of their center in Manhattan with the Technogym equipment. And here you see Dr. Lee Jones, which is the leading researcher on this project at the Memorial Sloan Kettering Cancer Center with some of his team. And I really thank Dr. Jones for having kindly provided to me the material for the presentation. Some background taken from Dr. Jones' publications. We know that cancer treatments are toxic from a cardiovascular standpoint. A treatment of 3 to 6 months determine a 10 years cardiovascular decline. But we also know that exercise therapy can reverse that decline with a multiple hit approach. Multiple hit means that we can target different variables, improving blood function, cardiac function, muscular and vascular function. So it seems that the answer seems quite simple. So let's exercise or even do research at a clinical center with optimal supervision, high technology, etc. But this conventional site approach could have some limitation in certain situations, especially from a research standpoint. It can be expensive. The training site could be difficult to be reached, etc. By example, as you see here into the slide. So the aim of the project of this DigitX approach is that of having the rigor of a site-based approach, but at the same time the convenience of a home-based approach. And the project is really well structured and well designed. It is sophisticated also, with different phases and collecting many data from exercise, from lifestyle habits, and from biochemistry. But I would like to focus on the exercise component that is innovative, because the patients, they receive literally at home a treadmill, which is delivered directly by Technogym. So both the hardware, the treadmill to do aerobic exercise, and the software, the platform that collects data through our cloud, is at the patient's home. Then they train for 4 weeks, and they are followed on distance by the clinical personnel and the exercise physiologists at the Memorial Sloan Kettering Center. And then after 4 weeks, the treadmill is taken back. So it is a very functional approach and really easy to be conducted by the patient. So they do not have to move from their home to the clinical center in downtown Manhattan, which is very complicated. But at the same time, they maintain the rigor the scientific approach, which is required when you conduct very sophisticated research protocol. So I think that I've finished my time, my 15 minutes as planned. I just tried to show to you, to present to you some given cases of exercise therapy collected from around the world, Italy, Australia, Germany, and the United States. It is clear that exercise therapy in cancer works. To do that, we need knowledge, we need proper technology, and we need passion. We are now ready to receive your questions. So see you in a while.
Hello. I'm hoping that folks can see me. No? Yes, we can see each other, right? Okay. All right, so I'm going to curate our questions and answers. Oh, good. Thank you, Megan, for letting me know you can see me. I'm going to answer a bunch of questions in rapid succession, and then I'm going to pose questions to Doctors Pauly and Zanuso. Okay, so to the OT, we need OT. We definitely need OT. To the practitioners who are interested in registering on the registry, please, please do so. There is the opportunity for anyone to register from around the world. And if you go to exerciseismedicine.org/movingthroughcancer, you'll get to that green dot, that green button that says, click here for the registry, and you can register your program or your services. And we welcome you. All of the programs and all of the practitioners going on to that registry are reviewed by me personally before they are then put into the registry. Someone wrote about the need for advocacy for cancer exercise trainers. Couldn't agree more. Moving Through Cancer initiative is all about that. Would love to hear from you if you have ideas. There was a college student that wrote, what do I do? My suggestion to you and my news for you is great news. There is an approval of a textbook called Essentials of Exercise Oncology that will be co-written by myself, Anna Campbell, and Anna Schwartz. We believe it is due out, I believe, in 2024, and will include some help for universities that are interested in offering a course on exercise oncology. So stay tuned for that. But for now, you need to make sure that you get certification as a fitness professional, and then in addition to that, go get specialty certification. And the gold standard for that would be the CAN Rehab program out of the UK, offered by Anna Campbell, and we're trying to turn that into an ACSM course as well. Somebody wrote about rare cancers. What do we do about the rare cancers? So it is true that about 85% of the research that is done in the area of exercise oncology is done on breast cancer. But the great news is when we do studies on rare cancers or on other cancers, what we find is that the results are very, very similar. And so certainly we need more research on those rare cancers, but we are fairly certain that our results are robust to a variety of cancers. I did want to say a big shout out to the fact that we have people on the line from Africa. We have people on the line from South America. Hello, Brazil. Certainly from China. Hello, Jean. I hope you're there. And certainly in Europe and in the US. And a particular shout out to my friends at Penn State. But from our friends in Africa, there was a comment that, heck, we can't get people without cancer to exercise. Why are we talking about exercise and cancer? And my answer really simply would be that it might be a teachable moment. It might be a moment when people are particularly interested. Somebody asked specifically, and this is for you, Dr. Pauly, about pre-participation screening and how we feel about the translation of a pre-participation screening module from other chronic diseases to cancer. Do you want to speak to that?
Pre-participation in that, if someone just comes to say, hey, doc, I want to start exercising, and
yes.
Gotcha.
Yes.
Yeah, so the, you know, in that setting, you want to mention all the benefits, and certainly determining, you know, if someone is fit enough or if there is some other medical condition whereby, you know, they shouldn't exercise. And I can tell you from experience that happens very, very infrequently, that, you know, even people with, you know, near end stage lung disease and heart disease and so forth, you know, the benefit of exercise is still there, individualized. And then repeat the second part of your question about the rehab.
Oh, no, I was just saying, if, you know, what do you think about, I mean, people have to do a pre-participation screening before they do. We screen people before they do cardiac rehabilitation, but then if somebody wants to exercise and they're currently going through cancer treatment, how would you screen them?
You know, I think just, I would do it the same way, you know, ask the questions, see where their fitness level is now, see if they have any adverse effects from exercise, obviously chest pain and you know, any syncopal things like that. But beyond that, I think you know, unless there's something, you know, very obvious, you know, I wouldn't make it any more complicated than that.
Okay. The second question for you, Dr. Pauly, before I switch to questions for Silvano, is this was very specifically worded for you. What is the best way to approach the medical community? What do you think about how we get your colleagues to recognize that there are professionals out here who can help their patients who have cancer?
Yeah.
How do we do that?
Yeah, exercise. Yeah, so as I mentioned, I do have expertise in the intensive cardiac rehab program, and to be honest, the best way to get their attention, clinicians' attention, is to have a program that is covered by their insurance, at least in the United States. You know, that was the big you know, threshold that the Ornish program and the Pritikin program and the Benson Henry program, those are the three that were approved by Medicare. You know, that's when they became, you know, household names, was when Medicare said, hey, you guys have reached the you know, the proof that we needed to say that these, you know, lifestyle medicine programs work, and therefore now we'll reimburse it, and then wherever Medicare goes, the commercial insurances follow. Because again, if we refer someone to a exercise cancer program, but it's not covered by their insurance and it's prohibitively expensive, they just won't be able to do it. And right. So I hate to say it's all about the money, but having it be more mainstream, I think, would be the first place to start.
Okay, well, there's so much more to unpack there, but I want to get to some questions for Silvano as well. So Silvano, I so enjoyed your presentation. It's really nice to see that the Memorial Sloan Kettering Group has adopted the shipping of treadmills approach. I published that back in 2015. So it's fantastic to see that kind of thing proliferating and happening elsewhere. So there were two questions very particularly for you about whether they wanted to know whether it was possible that eccentric exercise drives more myokines than concentric exercise. Any comments on that? I think there must be a delay for him. Are you not hearing me? Yeah, okay. So can I try it? Silvano, can you hear me? I don't think he can hear me. Okay, all right. I'm sorry about that question. Maybe you, whoever wrote that in, can follow up with Silvano separately. It looks to me like his internet might be a little unstable right now. I'm not sure. So then I'm going to answer a question that was written in. As a physiotherapist working in cancer rehab, I've noticed lack of referrals to exercise. So what are the challenges from the physician side of things for referral? And what I would say is I sit on the standards committee for the National Accreditation Program for Breast Centers in the US. And what I hear is that they have so little time and they find themselves with 15 things that are not covered by insurance, including exercise, that they need to talk about. And they're trying to figure out how they're supposed to talk about exercise when they also need to talk about fertility preservation and psychosocial distress and fiscal distress and other issues that are also not paid for by insurance. So there is an entire field of implementation science that is trying to address this at this point, and it is the purpose of the Moving Through Cancer initiative to try to answer questions like this. So I believe we've run out of time. Thank you so much for attending this session. And Silvano, do you want to close us out? Can you hear me? I don't think he can hear me. All right. Well, then I guess Dr. Pauly, Silvano, thank you so much.
Didn't grab the question. They might be no.
So,
Thanks, everybody. Bye-bye.
We have a few thank yous as we wrap up today. Thank you first to Drs. Schmitz, Pauly, and Zanuso for their informative presentations and Q&A session, reinforcing the benefits of exercise in cancer care. Thanks to all of today's attendees for your participation and questions. And thank you to Technogym for presenting today's symposium, for their continued support of exercise as medicine, and for their commitment to exercise for prevention and treatment of chronic disease. Have a great afternoon. This concludes today's symposium.
Hey there.